Hey, how's it going, guys? My name is Eric Singh. I'm your 2021-2022 education coordinator for the Brain Bee, and I just wanted to make this video on brain vasculature as well as strokes, and also the different symptoms that a patient can have based on the location of the strokes. This is really in preparation for your regional exam, your regional competition, wherein I'll have questions like. I'll show you guys a scan of a vessel saying, okay, this vessel is going to be occluded or have some kind of breakage or some kind of pathology associated with that vessel. And I'll ask you guys, okay, what is the disease state? What would you expect this patient to have? Right. So, and as I'll harp on later on, this is going to really these are really gonna be two-step questions, right? One, you need to look at a scan and be able to say, okay, this is what the vessel is, just by recognizing what the scan is and what the vessel that I'm pointing to looks like, but also is recognizing what part of the brain does that vessel supply and what does that portion of the brain do, right? So it's going to be more two-step questions in regards to how I test you guys on your regional exam, right? And this will be very helpful later on, especially if I'm going to medical school. This will be very helpful and very important for stroke disease and stroke symptoms, right? So yeah. So this is just very minor pre-lab quiz. It's because it's called a pre-lab quiz, I don't want you guys to get confused. This is just some questions to help you guide you through this presentation. However, it is not representative of the quiz questions that I made for you guys. These are a little bit too easy, so I most likely will not be. So I will most likely not be using these questions. It'll probably be a lot more difficult. For example, out of these questions, I will probably be asking you the last question, right? Symptoms based on stroke location, but I'll be asking you at a level above this. So for example, we'll go over this later on through the presentation, but a specific question that I could ask is, I may show you a scan, point to the pica artery. If you don't know what that is, don't worry. I'll be going over that later on. But let's say I have an arrow pointing to the pica artery. I will have an arrow pointing to it, and the question will say, what does this patient have if there's an occlusion to this artery? So, but I won't tell you it's a pica artery. I'll expect you to already know it based on an actual scan. So it's like a it's a two-step question where one, you need to know what the artery is based on a scan. And second portion of the question is figuring out or remembering or just being reasoned through what the symptoms would be based on what structures that artery supplies. So these other questions are a little bit too easy for me to ask you guys. Like, for example, what are the types of strokes? There's two types, ischemic, hemorrhagic. What is the circle of Wilson's components? I'll be telling you guys that later on. What is the blood supply of the heart through the head and neck? That is going to be the next slide. And what are the main blood vessels of the brain and what are their perfusion areas? This is basically the second question, just in a different wording. But yeah, so basically the main thing I want to get across in this slide is that even though it's called a pre-lab quiz, a pre-lab quiz, it is not indicative of what your quiz questions will be like. It will be harder than what I'm asking you guys here. Cool. So before we get to the brain, the blood, the cerebrovasculature, we need to go over the origin of blood flow, right? All blood flow originates in the heart. So we need to start from there and then we'll work our way up. So the first thing to notice is this, right? There's a certain acronym I use to remember this arch and these three big vessels coming off it, ABCs, right? So A for arch of aorta, B for brachiocephalic trunk, the right brachiocephalic trunk, C for the left common carotid, and S for ABCs for the left subclavian artery. So we notice that there's these two main arteries running up the neck that will eventually get up into the brain, right? So, but let's start off with the left brachiocephalic artery, right? Brachiocephalic, when you break it up, it's brachio and cephalic. Brachio means arm, cephalic means head. So as we see here, this brachiocephalic trunk, this left brachiocephalic artery, will bifurcate into an artery going up to the head called the left common carotid. This is the cephalic portion of this brachiocephalic trunk. And we have the right subclavian, which is going to the arm, the brachio part. And we notice here that this common carotid, this right common carotid will bifurcate again into the right external carotid and the right internal carotid, right? And this will the internal carotid, right, not the external. The internal carotid is what gets into the brain. The external carotid will supply the facial muscles and the mimetic muscles as well for expression and whatnot. Now, the subclavian is also very important. Despite the subclavian going to the arm, it's still very important for brain vasculature because we see this little artery branch off of the subclavian called the vertebral artery, the right vertebral artery. The vertebral artery will actually run through your cervical bones through your transverse foramen, and will go up and will combine, right? Just two of them. They'll combine to form this basilar artery, which will supply the posterior circulation of your brain. I have another slide on this, but I just want to tell you guys, I just want to repeat it right now. But the vertebral artery, it runs through almost all of the cervical spinal segments, except for C7, right? So the vertebral artery runs through the transverse foramen of C6 to C1, but not C7, right? That's a very important thing to remember. It runs through C6 to C1, but not C7 right here. All right. Now, moving on, we have the left common carotid in the same story here. It bifurcates into the external carotid, which goes to the face, the superficial area of the face, and we have the internal carotid, which goes invades deeper and will help supply the brain. And again, we have the subclavian artery right here, which will then bifurcate and form the left vertebral artery, which will then combine with this other right vertebral artery from the subclavian, which will then form basilar artery, which will then go to the posterior circulation. All right. So you got to know these two pathways of blood flow. Remember, vertebral is for posterior circulation. And there is one exception to this, which I will go over when we get to that slide. But it's something called fetal PCOM. And I'll go over that when this slide gets to it. And we have the internal carotid, which is meant for the anterior circulation. I wanted to present this website to you guys because this is a very valuable resource, Radiopedia. If you go to this site and look at all the disease states that we talk about, this will give you a lot of exposure to scans. Because all this website is scans that you can scroll through: MRIs, T1s, T2s, CT scans, in this case, angiograms, MRAs, CTAs. And this will allow you to get exposure to not just models, right? But because models are too perfect, right? No one's anatomy is perfectly like a model. And this will give you exposure to actual patient scans, right? So this is going to be great because I will try not to ask questions that shows models. I'll try and ask questions that shows either cadavers or a scan of the actual patient, or even in surgery pictures, which is filled with blood and is a lot more difficult to try and figure out. But if you really know your anatomy, then you can be almost a detective and use context clues of what you see that is obvious to help you figure out what the answer will be, right? And the reason I do this is because because to truly understand your neuroanatomy, you need to have a three-dimensional image of the entire brain, all the structures in your head. And by testing you guys on actual scans or actual surgical videos or actual cadavers, that will be more indicative that you know the 3D anatomy versus just showing you a model that you just memorize because it's on the PowerPoint, right? So basically, this site will be your best friend throughout the course. So this is just basically the same picture as before, but this is just with an overlay of the inferior portion of the brain. So we're looking at the underside of the brain. So basically, if I'm looking from your feet and up to your head, this is what I see. This is the inferior portion of your brain. And you see here in the posterior circulation, right? Because this is the cerebellum and the occipital lobe back here. So this is the posterior circulation. And we have the anterior circulation over here, right? So remember, vertebral for posterior circulation, and then the ICA for anterior circulation right here. So I'm just going to go through some of these arteries and vessels. In the lab, Riley, he drew the circle of Willis. So if you guys were in lab, you guys were able to take a picture of it. So I'm not going to redraw it here. But I will go through really quickly some of the arteries and stuff that you can see here. So I mentioned just now that the vertebral arteries are involved in the posterior circulation, right? And you guys can kind of see that these two arteries that are paired up would come from, or is trailing up the spinal cord, right? Where the cervical vertebrae are. So these vertebral arteries, they're running up C6 to C1's transverse processes and will end up here, right? So we have the vertebral arteries right here, and they will have a branch called the anterior spinal artery. Basically, before the vertebral artery become the basilar artery, it will give off a branch called the anterior spinal artery, which will then run down the front, right, anterior spinal, the front of the spinal cord, and will supply these areas. Now, you can't really see it here, but maybe a little bit right here, but you can't really see it too well. Maybe actually this one right here. Yeah, so maybe this one and this artery that doesn't show the cerebellum. This would be your pica, right? You can't really see it though, so, and I'm not entirely sure, so I wouldn't ask you that as a question because it's a little ambiguous. It's a little bit too low in an actual anatomy. So, but just know that the pica, right, the posterior inferior cerebellar artery, is going to come off somewhere around here before the basilar, right? The pica comes off of the vertebral arteries on both sides and will supply the posterior inferior portions of the cerebellum. Now, the vertebral arteries I mentioned, they will combine, they will converge with each other and will form the basilar artery. You can see how it kind of looks like a snake almost, snaking its way up this portion of the brainstem called the pons, right? So it's called the basilar artery because snake in Latin is basilisk, right? So they said, oh, it looks like a snake, we'll call it the basilisk or the basilar artery, right? And you guys can see here, we have something called the ICA, the anterior inferior cerebellar artery, right? You see here the anterior inferior cerebellar artery that supplies portions of the cerebellum, the anterior and the inferior portion of the cerebellum. So what's really important to know here is that the pica comes off of the vertebral artery, but the ICA comes off of the basilar artery, right? Very important to know this. And I just mentioned right here that this portion of the brainstem is the pons. So these little arteries that come off, these are called your pontine arteries, your pontine arteries, right? So moving up your basilar artery, we come up to this section right here. So there are two arteries that are very closely associated with one another. The one that's on the bottom, right, is called your SCA, your superior cerebellar artery. This will supply the top portions of your cerebellum, right? SCA, superior cerebellar artery. Now here, right, the artery right above the SCA is going to be your PCA, your posterior cerebellar or cerebral arteries, posterior cerebral arteries, right? This is going to supply much of your posterior circulation, so your occipital lobes, portions of your optic tracts, portions of your temporal lobe, the medial inferior portions of your temporal lobe, which is important in memory formation. That's where your hippocampus is. And we'll talk about later, this can cause some form of amnesia, right? So your PCA, posterior cerebral artery. Don't confuse this with I say posterior cerebellar artery, because that doesn't exist, right? And moving forward, right, we have this little artery right here. This artery communicates your posterior circulation with the anterior circulation, right? So we call this the posterior communicating artery, right? Posterior communicating artery, or the PCOM, PCOMM, right here. So the way that the anterior circulation works, right, is that the ICA will become the MCA, right, at the point where the PCOM attaches and where the ACA bifurcates off of the ICA, right? So if I wanted you to say that this is the if I wanted to point at a structure and I want you to answer ICA, I'm going to pin on the circle right here, right? If I pin right here on this circle right here, right here, I want you to say ICA. However, if I pin anywhere along here, right, on this main trunk that comes laterally to the brain, I want you to say MCA, right? MCA right here, right? So ICA if I point at the circle, MCA if I point to the trunk, the actual trunk that runs laterally. And we'll go more in depth on this in these bifurcations and whatnot, and its implications clinically. But moving on, we're almost done here. we have these arteries right here, right? So you see how it becomes like green, this a circle of Willis, but then also keeps on running, right? You can see here on better actually. You can see how it kind of is green, and then it kind of runs upwards along the medial portion of the frontal lobe. This is called your ACA, your anterior cerebral arteries. Anterior cerebral arteries, ACA, right? ACA. Anterior cerebral because it supplies the anterior portion of your cerebrum, right? And this thing right here, this little guy at the very top of the circle Willis, this artery communicates the left and right ACAs. It communicates the anterior circulation, so we call it the anterior communicating artery, the ACOM, right? ACOM right here. So that's just a broad overview of your main vasculature in your brain, right? We're gonna go more in depth on this about right now. So yeah. So now we understand the normal cerebrovasculature. Now we need to go over a little bit of the pathophys, right? And really, this is going to be in terms of strokes. So there are two main types of strokes, right? You have your hemorrhagic strokes and your ischemic strokes. So the difference is the hemorrhagic strokes are wet and the ischemic strokes are dry. And the reason why is because the wet or hemorrhagic stroke has a rupture of a blood vessel, right? So blood is actively pooling out into the brain parenchyma or the brain's functional tissue. So there's going to be a lot of bleeding because of all this pressure and because of the lack of blood flow. These cells in the surrounding area are going to die off. All right, and you can see in this picture right here, there's a lot of blood pooling in. And as you guys, I'm not sure if we'll cover this in clinical neuroanatomy lab, but I do in clinical neuroscience, something called the Monroe-Kelly doctrine. All right, basically the skull can't expand unless you're like a newborn and you have your fontanelles still open. But basically, the skull can open and it's a closed area. So if you have blood and more matter coming into this area, that means that but the area isn't increasing. That means it's an increase in pressure, which means that this increase of pressure can kill your brain cells, the cells in your brain. It can actually cause a cerebellar, a tonsillar herniation where there's all this pressure has to go somewhere. So it's going to go down the only hole that's big enough for this. That's near your foramen magnum at the base of your skull. So your entire brain is going to be pushed through this tiny little hole, and that will cause catastrophic brain death, cellular death, and ultimately global brain death. So very important, right? This is not good at all. Now, in terms of these dry strokes, right, we have ischemic strokes. So really, this is not a rupture of the blood vessel. This is more so a clot that will form and will get stuck somewhere along this artery, preventing any more blood flow from coming through. And this lack of blood flow means that no oxygen and no nutrients can get to these cells, which will then mean that they will die. The next slide will really explain some of the pathophys of why the cells are dying because of no oxygen and no nutrition. Now, another thing I want to talk about for these dry strokes are something called TIAs, or transient ischemic attacks. So basically, a TIA is very similar to a dry stroke, wherein there's a clot that's blocking an artery, but it's a small clot, so it's partially blocking it. But because it's a smaller clot, it only gets stuck maybe temporarily for maybe half a minute, 30 seconds. But then the pressure of the blood flow will push the clot along. So you may have some minor symptoms. You may have some symptoms for maybe like 30 seconds or so, but once the clot gets pushed through, then you're back to normal. Now, TIAs are very bad still because they are a significant risk factor for a full stroke that will be occurring pretty soon. And they kind of make sense, right? These arteries start off very big and then get smaller. So if a small clot gets partially stuck in a big artery, well, when it gets pushed through, it will get stuck in a smaller artery, which will then cause a full stroke. So even though you may have a TIA, and it goes away after like 30 seconds, you still want to rush to the emergency room because you want to be in a hospital setting when you do have this full stroke. And the name of the game for stroke management is you want to be as quick as possible, right? Minutes matter, right? It is 60 seconds can be the difference between having permanent deficits or actually brain death. versus having a completely functioning and healthy patient, right? So it's very important. Now let's go over some symptoms, right? If Because the king of neuroscience and the field of neurology and neuroresearch, any neuro field in the clinical environment or scans, you always get CTs, you always get MRIs, right? Because we can't see into the skull, right? So we need to get scans to be able to get a view of what's happening in the brain. However, like I said, strokes, they are occurring, minutes matter, and you don't have time to take someone down to a CT machine, get a CT, come back up, have it being dictated and looked at by a radiologist, and then seeing what happens, and then making a decision. We need to be able, in a clinical setting, we need to be able to immediately look at the symptoms and say, okay, this guy's having a stroke. Is it ischemic or is it hemorrhagic? Because there are significantly different outcomes depending on this type of stroke. For example, ischemic strokes are usually the mortality rate is lower compared to a hemorrhagic stroke, right? So it's really important that we know the difference between which type of stroke is happening. So for an ischemic stroke, right, the main symptoms is going to be location based, right? And I'll go over that. So for example, I mentioned earlier that the PCA, the posterior cerebral artery, supplies portions of the medial inferior temporal lobe. This is where your hippocampus is. So one of the symptoms of a PCA stroke is going to be amnesia, right? Also, it supplies portions of your occipital lobe. So you have visual problems or something called homonymous hemianopia. So that would be the symptoms of a PCA stroke. MCA can have completely different symptoms. ACA, very different symptoms as well. So it's really just based on the location, right? So the way to be able to differentiate maybe a brain tumor or or maybe an infection in the brain versus a stroke is that strokes are very acute, right? You are perfectly fine 1 minute, and then 10 seconds later, you're unable to speak, or you're unable to remember things, or you're unable to see properly, right? It's very acute. Whereas brain tumors and other diseases may take at least or take a lot longer than 30 seconds or 10 seconds, right? Now, a hemorrhagic stroke is similar, where that it'll have the same location-based symptoms, but it'll have the addition of a quote unquote worst headache of my life, right? So basically, in all the textbooks I've read, a patient with a hemorrhagic stroke will immediately have to go to the ER because of how horrific their headache feels. So an ischemic stroke, right, just a recap, an ischemic stroke, its symptoms are only location-based, whereas a hemorrhagic stroke, its symptoms are location-based, but it also has a severe headache, right? So hemorrhagic, severe headache and symptoms. Ischemic stroke just has symptoms, but no severe headache, right? So that's very important clinically and diagnostically. So I really don't need you to remember the minutiae of this slide. This is just to help you understand why an ischemic stroke still causes cell death, right? So I'm going to run through this very quickly just to cover all my bases, but this is not necessary for exam purposes. Basically, if there's no blood flow going to these cells, that means you're going to have no oxygen to that area. No oxygen means that you can't have any oxidative phosphorylation in the mitochondria, so you can't produce ATP through ATP synthase. No ATP means that all the active transports like the sodium potassium pump can function, which means that it can't maintain your resting membrane potential, which means that it can't maintain a negative 70 or negative 65 millivolt potential. This means that your cell will constantly depolarize, which will then mean that the calcium voltage gated channels will open up, allowing a constant stream of calcium into the cell. Calcium is very important in allowing vesicles to be released or neurotransmitters to be released. So this can cause upstream or downstream glutamate transport, right? And calcium also has other cellular processes which will release excess glutamate. Excess glutamate will then cause excitotoxicity because these neurons can't always be activated, right? So they'll go through something called excitotoxicity, wherein they'll start to die. They're just always activated, always stimulated. And that's very interesting because in many neurodegenerative diseases like Parkinson's, ALS, and even Huntington's, this excess of calcium influx, or this excess glutamate, which can cause excitotoxicity, which has actually been implicated in many of these neurodegenerative diseases. So it's very interesting how the parallels between a very acute symptom versus a very chronic disease that can take upwards of 10, maybe more years for it to kill somebody. But like I said, I spoke very quickly just because it's not necessary for you to know it. It's just to cover all my bases so you guys can have a full understanding if you care to, right? But it's not going to be required for exam purposes. Cool. So diagnosis, right? So we have three main diagnostic tools, right? And as I mentioned earlier, we can't look into the skull. So we're going to need some scans to figure out what's going on in the brain or what artery specifically is being occluded, right? Or is ruptured. So we have three different things we can use. We have CTAs, MRAs, and angiogram. CTA stands for computer tomography angiogram. MRA stands for magnetic resonance angiogram. And the third one is just normal angiogram. The first thing I want to cover is what is the difference between a CTA and an angiogram, right? Because the real difference is there's a computer tomography angiogram versus just normal angiogram. So they're very similar, wherein CTAs and angios both use X-rays. However, the difference is that a CTA uses a CT machine, which is just an X-ray machine, but it's spinning around your body, right? So a CTA will allow you to get a 3D image of the cerebrovasculature, which will allow you to zoom in, zoom out, rotate, and look at the vasculature from all different angles. Whereas an angiogram will only produce a 2D image of what's going on. Now, why would you do an angio versus a CTA, right? CTA would seem superior. Well, the difference is that a CTA takes time to do, right? It takes a few minutes to do, and then it has to be read by a radiologist. Then it needs to be processed through a computer to create this 3D render. However, an angiogram can happen instantaneously. So what many of these neurosurgeons and interventional radiologists do is that they will have the angiogram because they can see their catheter and where it's going in real time with this angiogram. Whereas they try to use a CTA, it will take a couple of minutes and it's not going to be very precise. And as I said before, for strokes, time is key, right? Minutes matter. So as I mentioned before, moving on from that, but as I mentioned before, CTAs, they take a few minutes. MRAs, they take 20 to 30 minutes, right? So that's just another thing to differentiate between the two. Now, CTAs always require an IV contrast, right? So, however, with the IV contrast, that means that you have to check their kidney health, because if the kidneys aren't functioning properly, then it won't be able to filter out the IV contrast properly. So before you do an IV contrast CTA, you want to check their creatinine levels and their GFR, their glomerulus filtration rate. And both of these things will test kidney health, right? If your creatinine levels are too high, that could be indicative of tissue death, or more specifically, kidney death. GFR, if it's too low, that means that the kidneys aren't filtering optimally. So that may be contraindicated for doing a CTA. MRAs, one, you don't need to worry about kidney health, but you do need to worry about MRI safe implants, right? So if it's a metal that is magnetic, that will cause a lot of heat and can damage and kill the person, right? Also, I mentioned there on the slide that MRAs, not all of them have contrast, but you do want to use contrast called gadolinium if you want a very good picture. So, but however, MRAs, you cannot inject a gadolinium contrast into a pregnant woman because gadolinium is a metal ion. And when it's in its free metal ion form, it's actually very toxic. So for that reason, we give this gadolinium contrast in its chelated form or a bound form. However, gadolinium is water soluble, so it's able to cross the placenta into the fetus. And when it crosses, it will leave behind the chelating compounds, which will allow it to be in its free ionized form. This will then be able to cause significant damage to the fetus and can kill it. So you cannot give. So you don't want to give a MRA with contrast in a pregnant lady. And yeah, so that's about it. So this is actually a pretty interesting picture. This is a 3D render from a CTA, right? So you see here you have your arch of aorta, brachiocephalic, left common carotid, left left subclavian. Sorry. All right, you have your internal carotids coming up into your anterior circulation, vertebrals and basilar coming up into your posterior circulation. I mentioned before that your vertebral arteries pass through the transverse foramen of C6 to C1, but not C7. All right. So, and the last thing I want to mention here is the basilar artery, right? It is responsible for most of the posterior circulation in the brain because it supplies oxygenated blood to the brainstem and the cerebellum. However, I mentioned that there is one exception to this rule called fetal PCOM, right? So people with a fetal PCOM, basically their posterior communicating artery is very big, like the very dilated and is bigger than in other people. So basically what happens is because of how big it is, right, the PCOM is actually provides more blood flow to the posterior circulation than the basilar artery. So that's actually one exception to the rule, right? So in these patients, the posterior circulation is the basilar artery is not responsible for the posterior circulation in patients with fetal PCOM. Is actually the posterior communicating, which is responsible for the posterior circulation. And this is in about 20% of people, right, who have a fetal PCOM, right? So 20% of people, their PCOM is responsible for the posterior circulation, not their basilar artery. From the other 80%, their basilar artery is. So that's actually a pretty cool clinical pearl to remember. Something that is along the same vein of that is that there is a lot of variations in people's bodies in general, but more so in their cerebrovasculature. For example, our circle of Willis, right? Your PCA, PCOM, ACA, ACOM, right? They seem very important. So you think everybody would have a complete circle of Willis because it's your brain. However, in clinical studies, only 30% of people actually have a complete circle of Willis. So it's something very interesting to notice. A lot of people, they have an absent TCOM, and they have an ACOM that's completely gone, right? So there's a lot of variation in 70% of people. So something that's interesting to know. Cool. So now we've gone over a lot of the vasculature and the diagnostic scans. Now we need to go more in depth on some of these arteries. For example, we need to go more in depth on the middle cerebral artery because, as I'll show you guys when we talk about symptoms, the part of the MCA that's occluded is very important. We have to be very specific because an occlusion to the neck has different symptoms from occlusion to the deep MCA or the lenticulostriates, which is different symptoms from an occlusion to the superior trunk of the M2 or an occlusion to the inferior trunk of the M2. So now we need to go over terminology, right? So I mentioned that acronyms are king in the hospital, right? Everybody uses acronyms. Instead of saying the middle cerebral artery, we say the MCA. Instead of saying the intracarotid artery, we say ICA, right? So instead of the SCA, or instead of the superior cerebellar artery, we say the SCA. However, in a lot of these arteries, we need more abbreviations. One, because we need a way to really be able to differentiate what part of the MCA is damaged, right? Because different symptoms, because if this is damaged, it'll have different symptoms. This is damaged, it'll have different symptoms. If this is damaged, it'll have its own separate set of symptoms. So we need more specificity. So instead of calling this entire thing the MCA, we use M1 and M2. So the way it works is the number 1 is always designated as the largest part of the artery or the base of the artery. So you see here the ICA, and then the MCA starts here. So this whole portion is called the M1 segment. But then you see here it bifurcates, right? So this is called the M2 segment, right? M2 segment. And with the MCA, it branches multiple times. So we get M1s, M2s, M3s, M4s, but we don't really worry about it too much. PCA, for example, is the same thing. We have M1s, M2s, and M3s when it bifurcates. ACA is the same way. It has M1s, right, before the ACOM, M2s after the ACOM, and A3s after the bifurcation, the callosal marginal artery. All right. But yeah. So let's go over what structures these things supply, because this will be very helpful when I go over some of the symptoms. When I go over the big chart with the symptoms, this will be very important because the MCA is a very big artery that supplies many portions of the brain. So as you see here, we have the M1 segments, right? The base of the MCA. And we have these three arteries, right? That are is more than just three, but just for the simplicity of a model, we're just saying that there are three arteries, but it's actually numerous arteries that are called the lenticular striates. Another name for the lenticular striates is called the deep MCA arteries, right? So deep MCA arteries or the lenticular striates. So these will go to a portion of the brain called the basal ganglia, right? So here's another picture to show it, right? So lenticular striates or the deep MCA arteries, right? You can see here, this is the M1 branch, right? All M1 branch, and then we have the M2s right here. However, we see that these arteries, the lenticular striates, the deep MCA branches, will go to this area called the basal ganglia. This is very important in movements, right? So we have like your caudate, the head of the caudate. We have your putamen, and then the globus pallidus, portions of your internal capsule right here, right? So it's very important in movement. So as you guys will see later on, one of the symptoms of a deep MCA stroke is motor deficits, right? Motor issues, right? So that's just to kind of give you guys, show you guys visually where these lenticular striates go. They go deep into the brain, into the basal ganglia. The other set of arteries I want to talk about off the MCA is going to be the superior trunk of the MCA, or the superior M2. This is going to go upwards and go into your frontal lobe, right? So you see here, right, you have your M1 branch, lenticular striates, or the deep MCA. And then there's this bifurcation where this is the superior M2s, inferior M2s. And you see here, the superior M2s goes into the frontal lobe, right? So one of the main structures in the frontal lobe is going to be Broca's area, right? So if you guys have ever heard of Broca's area, this is important, the actual moving your mouth and your tongue for speech, right? So a patient with Broca's aphasia is going to be having very hard, labored breathing. They are talking. They won't be able to talk very good at all. It will be very difficult to talk. They will have a lot of stuttering, a lot of pauses in between their words. It's going to be technically very difficult for them, right? So superior M2s, frontal lobe, but more specifically Broca's area in terms of symptoms. Now, the last branch of the MCA I want to talk about is going to be the inferior trunk of the MCA, or the inferior M2s. This is going to go downwards into your temporal lobe right here, right? You see here, you have your M1 branch, deep MCA, or lenticular striates, and then the bifurcation of the superior M2s we just talked about going to the frontal lobe, and the inferior M2s going to the temporal lobe. One structure in particular that we need to mention is Wernicke's area. So damage to the inferior M2s is called Wernicke's aphasia. So basically, Wernicke's area is important in making sense of words and saying them in the right order and the understanding of words. So, but it's not necessarily saying the word, it's just saying the right word or the understanding of what word you're saying. So this is going to be very different from a Broca's aphasia, because a Wernicke's aphasia, they're going to speak very confidently. They're going to have a constant flow of speech, right, the way I'm talking, but it'll be nonsense. It'll be something called word salad. So in lab, we showed you, we had you guys listen to specific examples. But for example, if instead of saying I am making a presentation for my lab, instead, if I were in aphasia, I would say I purple toucan, fruity pebbles to the door, right? I'm confidently saying it. I think I'm saying the right thing, and I have the right cadence when I say it, but the words make no sense. It's complete nonsense. It's something called a word salad, right? So yeah. So recap: main branch of the MCA, right? M1, deep MCA arteries, lenticular striates, which is involved in motion, right? Moving your body. Superior trunk of your MCA, superior M2, which is involved in your frontal lobe and Broca's area, and the inferior M2, which is involved in the temporal lobe or Wernicke's area. So this is something I will touch on later on, but I want to mention it now somewhere on this slide. And I'll actually use this slide right here. It'll be easier to show. So imagine we have an ischemic stroke to your superior M2, right? You have a clot that's right here. Well, that means that no blood can get to this area, this part of the artery, which means that this entire portion of the brain is going to die, right? So this is actually very important, because only this portion of the brain is going to die. However, if you have a clot, a very big clot at the base of the MCA, at the neck of the MCA, right? Well, blood flow can only go in one direction. It can't go backwards. So there's a clot right here. This means that blood can't go anywhere here. So that means that there's no blood going to your lenticular striates, and there's no blood going to your superior MCA or your inferior MCA. So if you have a clot at the neck of the MCA, that means that this entire portion of the brain will die, this portion of the brain will die, and this portion of the brain will die as well. So yeah. Now this brings up another point, which is that in models, and actually I'll show you this real quick, but I'll come back later. So looking at this slide, we see that there are specific areas of the brain are supplied by one specific artery. Whereas in actuality, this is not correct, right? This is just shown in black and white as, oh, this part of the brain is supplied by this artery. This is supplied by a different artery. In actuality, this isn't necessarily true. There's actually a lot of overlap, you know? The reason it's shown this way in the model is because it makes more sense visually and helps the student learn better. So for example, the ACA, right? This part of the brain, this little border, is applied by both the MCA and the ACA. And it kind of makes sense from an evolutionary standpoint, because if you have a clot in one of these arteries, well, you don't want to lose all blood flow to this portion of the brain. You want to have a secondary artery that can help supply this portion of the brain and maybe preserve some function, if not all, right? So this will be important in terms of symptoms, because there's some overlap in the symptoms. That's why it's important to notice. But yeah, this is one of the shortcomings of these models that we show you guys, is that it's not all black and white. There's overlap, there's borders, something called watershed areas in the brain. That's the specific name. If you guys want to look it up more into it. But yeah. So going back to this slide, there's one more thing I want to show you guys here on this slide, is the recurrent artery of Hübner, right? As I mentioned before, the lenticular striates, the deep MCA arteries, they supply the basal ganglia, and they're a branch of the MCA. However, a branch off of the ACA called the recurrent artery of Hübner, you can see it actually goes to the basal ganglia as well. Similar, so this is exactly what I said earlier about overlap of blood flow. So there's a MCA occlusion. The majority of the basal ganglia will die, but some of it may still be alive because the recurrent artery of Hübner is still providing blood flow by the ACA, right? I also want to point this out because this is very easy if you're shadowing, or if you're on your third year rotation, fourth year rotations, your fourth year externships. It would be very easy for a neurosurgeon or neurologist to ask you, okay, what is the blood flow to the basal ganglia? If you just say the lenticular striates, you will be incorrect, because it's also the recurrent artery of Hübner. There's also other clinical implications, but that's beyond the scope of this class. So you guys don't have to worry about that. But yeah. Also, just a quick review from the first lab. This is a coronal cut of the brain. So yeah. So I will be going more in depth on this slide. It's just a slide to just say in a very wordy way what parts of the brain are supplied by what arteries. So your anterior cerebral arteries, you mentioned, they will kind of form like a mohawk, right? It will supply the medial portion of their frontal lobe. So in word form, it will supply your frontal, prefrontal, cerebromotor motor cortex, and parts of their primary motor and primary sensory areas. So this is all part of your frontal lobe right here, all part of your frontal lobe. This is the most anterior portion of your parietal lobe. So your anterior cerebral artery will supply all the medial portion of your frontal lobe and the very anterior portion of your parietal lobe as well. Your anterior communicating artery is a very small artery. Remember the thing that connects your two ACAs, and this will supply the majority of the medial surface of the hemisphere. This kind of makes sense based on its location, because on the medial portion of the brain, so it'll supply the thing close to it. And as we'll talk about later, things such as the lamina terminalis, parts of the optic chiasm, and stuff like that. Your posterior communicating artery is the thing that connects the anterior and posterior circulation. And these arteries, the branching arteries, will actually run medially and invade into the brain structure. So it will supply portions of the optic chiasm and the optic tract, so vision, the posterior portion of the hypothalamus, portions of your mammillary bodies, and part of the thalamus. And finally, we have the PCA, your posterior cerebral artery, which is applied to the posterior circulation. So your occipital lobe, the inferior portion of your temporal lobe, right? So this is why it will cause amnesia. And then deeper structures such as the thalamus and the internal capsule. We'll talk about the internal capsule in a future lab, but basically the internal capsule is the nerve tract that connects the information processed in your cortex down to your limbs. So I've shown you the motor homunculus, right? And I'll have another slide on called the motor homunculus, where different parts of your cortex process information to move parts of your body. So there's the medial portion of your MCA, of your frontal lobe, will supply your legs. And then more laterally, it'll supply your arms. And most laterally, it'll supply your face, head, and tongue and mouth. But this information, right, it gets processed in the cortex, but it needs to get down to your limbs to actually move your limbs, right? The information has to go downward. So you need a wire, right? Kind of like in a computer, you need a wire to connect two parts of the computer. So this is what we call the internal capsule. So the information processed in your cortex will go down something called your corona radiata, which will then become your internal capsule. The internal capsule will take that information down to your spinal cord and out through your limbs to be able to move your hands. So the internal capsule is literally just a structure that we use as a wire to convey information, kind of like an axon, but is many axons, right? Cool. So now we get to the perfusion areas of the brain. As I mentioned before, the ACA kind of runs underneath the brain and like curls upwards over your frontal lobe. So you see the ACA is going to form kind of like a mohawk, or it'll form like a mohawk as area of perfusion. And we see here, remember, the superior branch of the MCA supplies a frontal lobe. So we see the MCA superior branch supplying the frontal lobe. Down here in portion of the upper temporal lobe, where the Broca's area would be, or sorry, Wernicke's area would be, we have the inferior division of the MCA being supplied here. And right here, remember, we have the deep MCA branch, or these lenticular striates, supplying your basal ganglia, right? Basal ganglia right here. Remember, I mentioned how the PCA supplies the medial and inferior portions of your temporal lobe, so PCA right here. And we have some of those deeper penetrating arteries of the PCA, which will supply parts of your thalamus and stuff right here, right? So so I hope that this is kind of coming together now, wherein the previous slides was setting up to this, right? Showing you in a visual form what arteries supply what in the brain. But remember, there's a lot more nuance to this, right? All these areas of the brain, there's a lot of arteries that may supply this portion of the brain right here, not just the MCA inferior, superior, and the deep MCA branches, right? Even here, some parts of this can be the ACA, some parts of this can be the MCA, so very important to recognize there. But I hope this is kind of coming together now at this point in the presentation, or at this point in the video. Cool. So now this is the main event almost. This is the main portion of your lecture. Everything before this was to prepare you for this slide and this chart right here. But however, I will be being a little bit repetitive to make sure that you guys understand this. So to start, we should probably discuss how this chart is organized. So the columns going down are the sides of the arteries, right? So left MCA is the first column. Second column is your right MCA. Third column is ACA. And the fourth column is a PCA. And then the rows signifies what specific branch of that that artery that's designated by the column title. That's what it is. So for the first one's case, these are the symptoms of a left superior MCA, right? Left inferior MCA, left deep MCA, and left neck of the MCA, right? So that's kind of how it's organized. So let's get started. And so really what I need you guys to do is I'm just going to kind of tell you guys what this chart means, right? So you really need to know what the symptoms in this chart are, but more importantly, what I want you to know is understand why, because that's where the real learning occurs, right? You need to understand why the symptoms are this way, not just memorizing. Because trust me, in the previous semesters, we were told to just memorize it. We weren't really explained why, and it was not a very fun time because there's a lot of overlap. For example, left homonymous hemianopia. We also have right homonymous hemianopia. So it's a lot of overlap, and it can be very confusing if you don't really understand why some of these occur. Some of these things occur, but I digress. So starting off, we have symptoms of the left superior MCA. So we have right face and arm weakness to start off with. So I want to refer you guys to this motor homunculus picture that I included at the very top. So as you guys can see, right, this is the frontal lobe, right, the primary motor cortex, right. So this is in the frontal lobe, right, very close to the parietal lobe. But basically, the medial portion of the frontal lobe controls your legs and your bladder, right, legs, bladder, and pelvis. And then the more lateral portion of your motor homunculus is your face, your hands, and your arms, and parts of your torso, right? If we go back to this picture right here, the ACA is a medial portion, and the MCA is a lateral portion, right? So the ACA is supplying blood to this part of the frontal lobe, and the MCA is supplying blood to the lateral portion of the frontal lobe, right? So that's why this is the explanation as to why a MCA infarct will cause right face and arm weakness, but an ACA infarct will cause right-legged weakness. The reason being, again, is because if the ACA is occluded, then that supplies blood to this part of the brain. Well, this part of the brain will die off, and if this part of the brain dies off, then you have loss of function, which is leg movement. So the ACA will cause right-legged weakness, whereas MCA, which controls this area, if there's an infarct to the MCA, it'll cause death to this part of the brain, and death to the brain will means loss of function for that area. So you will have right face and arm weakness. If you have any questions about that, just send me an email or send a text in the group me. But yeah. And then as I mentioned before, superior MCA, right, it will cause Broca's aphasia on the left side. So one thing to notice here is that Broca's aphasia and Wernicke's aphasia only occurs on an infarct to the left MCA, not the right MCA. The reason being is something called brain dominance, right? Have you ever heard of someone being a left brain or right brain? That is kind of like pseudoscience for what this concept is. A person who's left-brained, who's left dominant, has their speech areas in the left side of their brain. People, and you may have heard the old saying that, people who are left-handed, they're right side dominant. People who are right-handed are left-sided dominant. And that's not necessarily the case. There is a correlation there, but it's not necessarily the case. So almost 100% of people who are right-handed are left brain dominant, but people who are left-handed, only about 30% of them are right-sided dominant. So that means that the majority of people, regardless of left or right-handedness, is going to be left brain dominant, or their Broca's area and the Wernicke's area is going to be on the left side of the brain. So it's very important diagnostically to know, if you're a neurosurgeon, especially if the brain tumor is at an eloquent area, then you would definitely want to know their handedness, because if they're left-handedness, you may want to get some additional testing to confirm, okay, is he left or right brain dominant? But if he's right-handed, you can pretty confidently say, yeah, this guy is his Broca's and Wernicke's areas on the left side. But yeah, so just because Broca's area is in the frontal lobe, where the superior artery is at, left superior MCA, the left superior M2 branch is at, that's why you would cause Broca's aphasia, because of death of the associated tissue. Moving on, and also, by the way, it'll be right-sided face and arm weakness, even though it's the left MCA, because these things are contralateral, right? So the cortex, we talked about the internal capsule, right? So the cortex, right, processes information. That information will be taken down the brain via the internal capsule, and then it'll go down to your spinal cord. At the bottom of your brainstem, the medulla, that information is going to cross over some place called the pyramids. They're going to cross over. So the information that processes on the right side will actually go to your left side of limb. So it's contralateral. And almost all of your tracks from your cortex down to your body switch. The only exception is going to be a couple of tracts in the cerebellum, but it's only because they switch twice. So it'll be the first switch will be contralateral, but then it'll switch back to the same side again on the second switch. And we'll go over that in a future lab. But again, so if we're going over the left inferior M2 branch, right, you're going to have the same right face and arm weakness. And also you're going to have Wernicke's aphasia because we discussed above, the inferior M2 branch is going to go into the supply the superior temporal lobe, which is going to house Wernicke's area. And damage to that area will cause Wernicke's aphasia, right? Now, moving on, we have left deep MCA branch, right? So remember, this is the lenticulostriatus that will supply the basal ganglia. As I mentioned before, the basal ganglia is important in motor functioning. So as a result, this will cause right pure motor hemiparesis, right? So hemiparesis is when there is weakness on one side of the body, in this case, the right side of the body. Let me see. So if you see on the right MCA, at the neck of the MCA, this is hemiplegia, right? Hemiplegia is different from hemiparesis. Hemiparesis is weakness. Hemiplegia is complete paralysis. However, I will not ask you to differentiate these two terms. One, I think that is a little bit ridiculous. That's just a little, that's kind of mean, to be honest with you. And two, because there's varying degrees, right? Not every single case of left deep MCA is going to cause hemiparesis, and every single case of right-sided neck MCA is going to cause hemiplegia, right? The person who made this PowerPoint previously, so remember, I had adapted this PowerPoint and I kept the same chart, but the person who used previously, I'm not entirely sure why they would use vocabulary. If it were me, I would change this vocabulary to say hemiparesis as well, because there's varying degrees when you have an infarct to these vessels, right? It's just depending on just a lot of factors in terms of timing and when it gets treated and how it gets treated. And actually the individual itself, how much plasticity they have, right? So don't worry about hemiplegia or hemiparesis. This is just me to give you some vocab, right? Hemiparesis is weakness, hemiplegia is paralysis. So it's like a step above hemiparesis. Now, I mentioned previously that if you have an occlusion to the neck of the MCA, it'll be a combination of all these other symptoms, because if it's at the neck, then that means blood can't get to any of the branches. It can get to the deep MCA, the inferior MCA, or the superior MCA. So in this case, you're going to have first global aphasia. Global aphasia is basically having both Wernicke's aphasia and Broca's aphasia. So it's a combination of these two symptoms, right? You're going to have right hemiparesis because of the face and arm weakness on both MCAs, the superior and inferior MCA. Hemianesthesia, which is the inability to feel pain. So you can still feel touch. You can still feel things. Like if you have if you get pricked with like a pin needle, you'll feel the pressure of the pin needle, but you won't feel like that little pinch of pain, right? So you still have the sensations, but you won't, minus the pain. And it's something called right homonymous hemianopia, right? So right homonymous hemianopia is going to be when you're unable to see the right side of your world, right? And in lab, I explained this is different from losing just your right eyeball, because you still see some of your right vision with your left eyeball, right? You can try, but if you close your right eye, you can still see stuff on the right side, right? This is just your brain is unable to process the information because the MCA, especially at the base of the MCA, it supplies a structure called the optic tract, right? So if you think about it, your eyeballs are in the front of your head, and your occipital lobe is going to be in the back of your head. But how does that information get from the front to the back, right? It's just like a computer. It needs wires, right? It needs a connection, a conducting apparatus to get the information from the front of the head to the back of the head. And the MCA is in the middle. So it's going to supply parts of this wire. And so this is going to cause right homonymous hemianopia because there's going to be damage to the optic tract. And when we go over cranial nerves, we will go more in depth on this topic. And then the last symptom is a combo of above. I'm not sure why they said that, because all this was a combo above, but that's whatever. So moving on to the right MCA, right? We're gonna have left face and arm weakness, right? So remember, this part of the brain is gonna die because of the infarct. So it's gonna be the face and arms. And it's gonna be left side, it's contralateral. So if it's a right MCA infarct, it'll be left-sided arm and face weakness. And we also have a different symptom, right? So instead of Broca's aphasia and Wernicke's aphasia, we're going to have something called hemi-neglect, right? So basically, hemi-neglect is when you don't have an issue with your vision, but you have an issue with processing any sensations or stimuli on the opposite side of your body. So hemi-neglect, for example, is going to be something like the clock test I explained in class, right? Where if you ask them to draw a clock, they'll only draw the right or left side of the clock, and they won't be able to, and they'll think it's a perfect clock. They may draw from 12 to 6, but not 6 to 11, right? Because they only recognize half the clock. In a patient in a clinical setting, though, the best way to identify hemi-neglect is if it's a male, half their face will be unshaven and unkempt. Whereas for a girl, if she comes in, she may only have makeup on half her face, right? Because they just don't recognize, oh, I have the other side of my face to put makeup on or shave, stuff like that. Now, when we move down to the inferior MCA, we have something called profound hemi-neglect. Again, I took this PowerPoint from a previous TA, and I'm not entirely sure why they would add this. Profound hemi-neglect is basically just a more severe hemi-neglect syndrome. So basically, they're going to have more of these symptoms, right? So in a normal hemi-neglect, they may just fail the clock test. They may only draw half the clock. But in profound hemi-neglect, then they may also have the clock symptoms as well as half their face being unshaven or without makeup on, right? So there's going to be more symptoms. There's going to be a deeper hemi-neglect, worse hemi-neglect, right? And then you're also going to have your visual and sensory deficits. So remember, visual deficits because it helps apply the optic tract. All right, so you're gonna have those visual deficits. And it's also gonna have sensory deficits because if you remember from the previous slide, the MCA also is going to be important in supplying the parietal lobe, which is all about integrating all of your senses. So you're gonna have some sensory deficits as well. Especially, it helps supply your somatosensory cortex, which is at the most anterior portion of your parietal lobe. So that's how it may cause your sensory deficits as well. Now, there is also sensory deficits in a left MCA, but I didn't add that because the most common symptoms is going to be Wernicke's aphasia, right? The person is going to be unable to speak or speak very weirdly before you recognize that they have sensory deficits. The sensory deficits are still present in a left MCA infarct. However, it's just going to be less, it's just going to be crowded out by the more severe or the more recognizable symptoms of a stroke. Right. Now, moving on, we have left pure hemiprese. So same reason as this one. It's just this contralateral, so it's going to be left-sided on the right MCA because it goes. These are the lenticular striates, right? They go down to the basal ganglia. And finally, we are going to have very similar story as the left side. And you're going to have your left-sided hemiplegia. You won't have your global aphasia because this patient is a left-sided dominant brain, so they won't have any aphasia on this case. But they'll still have the same hemiplegia or hemipresis. It doesn't really matter, to be completely honest with you, in terms of test-wise. And this is not very accurate because there's varying degrees of paralysis or weakness. You're going to have some left hemi anesthesia, as I mentioned before, and you're going to have left homonymous hemianopia due to damage to the optic tracts when you have an infarct to that area on the contralateral side. And then combo above. Again, I don't know why they said this because all these symptoms are a combination of the above. But moving on to the ACA, the third column. Now, as I mentioned before, right, ACA is going to supply this part of the brain, but when there's an occlusion to this part of the brain, part of the brain is going to die off. So it's not going to be able to function appropriately. And this part of the brain, its function is to move the feet, legs, and the bladder. So as you guys can see here, you're going to have your right-legged weakness and as well as your incontinence, right? So because of this reason about occlusion to damage to this part of the brain, you'll have your right-legged weakness and your incontinence. Now you have a different symptom called right cortical type sensory loss. So the ACA, right, is going to be powering, or it's going to be it's going to be supplying much of your frontal lobe. And one of the functions of your frontal lobe, other than motion or coordinating motor activities, is going to be interpreting, right, higher order functioning of your senses. So because your MCA is powering or supplying your parietal lobe, you're going to have gross sensory deficits. However, is different because your frontal lobe is not involved in processing sensations. It's involved in integrating, but also combining and making sense of those sensations. So this won't be gross sensory loss, right? If you have an ACA stroke, you're still going to be able to feel the table, right? You're still able to feel and know, oh, I'm touching something, or oh, I'm getting poked by something that hurts, or I have a bee sting, right? What you will not have, right? What right cortical type sensory loss is a higher function of these sensations. For example, you're going to have two main things: stereognosis, right? Stereognosis and graphesthesia. I mentioned this in class, but stereognosis is being able to like close your eyes and feeling an object and knowing what it is just by the feel and touch, right? So it could be something as complex as a comb or your keys, or something as simple as holding up a cube block or a triangular block, right? You won't be able to recognize what it is because you can still feel that you're holding something, but your frontal lobe that integrates and is a higher functioning systems is not working properly because it's dead. It's not working properly because it's dead because of the infarct. So it can't make sense of that information, right? So that's what right cortical type sensory loss is. It's going to be your stereognosis and your graphesthesia. Graphesthesia is going to be if someone traces some kind of symbol on your skin, you would be able to tell what it is. So right now, if you're able to draw an S on your hands and close your eyes, you would know that there's an S being drawn on your hand. Or if you draw an E, right, you'd be able to feel, oh, there's an E being drawn on my hand, or some kind of letter or some kind of symbol that you recognize. You would be able to feel all those things. And finally, we have the symptom of grasp reflex and behavioral reflexes, right? So this is like your grasp reflex, your motor reflex, etc. So basically, as a baby, right, you have these primitive reflexes because they're all spinal tract reflexes, right? Reason being is because your brain cannot communicate very well or very fast with your spinal cord because when you're born, you don't have the correct amount of myelination. You're very demyelinated. So if you don't have any myelination, then a lot of your signals can't get down to the rest of your body. So your body, so when you're born, your survival instincts relies heavily on your spinal tract reflexes, because the brain is able to communicate. The brain is able to send information down. Similarly, when you get older and you about 6 to 18 months, you start losing all of your reflexes. That's because your spinal cord is fully myelinated, and your brain is able to now send information down to your spinal cord. One of the things that your frontal lobe does is it will inhibit these reflexes and will allow for more conscious reactions to stimuli. However, similar to how when you're a baby and your brain couldn't send information down because the axons weren't able to propagate that signal enough. If you have damage to your brain, like in an ACA stroke, then it's not able to send any signal at all. So basically, when you're a baby, the wires aren't correct, and with the stroke, the source that will send the signal down the wires isn't working. So it has the same end result, So that's kind of how you have the grasp reflex and behavior reflex, because your frontal lobe normally would inhibit them, but when it's damaged, it won't send those inhibitory signals. So you start to have those grasp reflexes again, right? So moving on to your right ACA, you're going to have the contralateral leg weakness because it damaged this area. You're going to have some incontinence because of your bladder, your detrusor muscle. And you're going to have your cortical type sensory loss, your stereognosis, and your graphesthesia. And your grasp reflexes because of the reason just mentioned above, the loss of the inhibitory signal from your frontal lobe because of that damage there. Now, moving on, we're going to be talking about your PCAs, right? Your left and your right PCA. For this, I want you to completely forget all these symptoms except for the first and the last symptom. These are so they're very esoteric in a way, but more so not because they're difficult to learn or they're not useful, is that in a clinical setting, you're never going to actually use this, right? Like the thing that's going to lead you on to a PCA stroke, the first things that you're going to try and look at is, okay, what kind of visual deficits does he have? And does he have any associated amnesia with it? Because once you notice that he has some visual deficits and maybe some memory loss that's very acute, then you would send him in for a scan to figure out, is this a PCA or is this a MCA, right? But if you want to differentiate between the two without a scan, the presence of amnesia is going to be a telling sign between PCA. as well as motor deficits on the arms or face, right? Could help you say, oh, this is an MCA, not a PCA. But yeah, so let's talk about why these symptoms occur. So in a left PCA stroke, right? Remember, the PCA is involved in the posterior circulation of the brain. This involves your occipital lobe. So it will make sense that it could also cause right homonymous hemianopia. But wait, why is this the exact same symptom as a MCA stroke, right? Because in the MCA, it blocks the connection between your eyeballs and your occipital lobe. So wouldn't it be a different symptom? Like it may still be visual deficits, but wouldn't it be like a different symptom? And no, not necessarily. If you think of a lamp, right? When you plug a lamp into the wall, right? The energy, the electricity goes through from the wall, through the wire, and into the bulb to glow. In the MCA example, right, when the optic tract is damaged, the wire is cut, right? The wire is actually cut, so no electricity can go to the bulb. In the PCA stroke, right, the wire is perfectly fine, but the bulb, in this example, the bulb is blown. So despite the energy electricity going from through the wire to the lamp, the bulb is blown, so it won't show any light. So there are different reasons, right? Optic tract for MCA, occipital lobe for PCA, but it has the same end result, right? So that's kind of the analogy I use to make sense of why the symptoms are the same. And finally, I mentioned that the PCA supplies the medial inferior temporal lobe, also called the entorhinal cortex, which houses your hippocampi. So it can possibly cause amnesia. However, for amnesia to form, you need damage to both sides, right? To both of your hippocampi. So the amnesia would occur if you have a pre-existing injury to the other hippocampus. Then if you have PCA stroke to the opposite side, then you would have amnesia. But if you have a perfectly healthy male or female, they may not get amnesia because the other hippocampus is still functioning for LTP or long-term potentiation, right? But it's just something that I found really interesting, which may be very useful. Now, moving on, we have the right PCA. So it's going to be a contralateral left homonymous hemianopia, right? Before the reasons explained above, because damage to the occipital lobe, it can't process this visual information coming from the eyeballs. And finally, we're going to have amnesia, possibly have amnesia as well. So again, disregard the middle symptoms. Only remember the first and last symptoms, right? Only remember the first and the last symptoms, all right? So that's about it for this chart. If you have any questions, send me an email or just send me a text through the group meet, all right? I'll be happy to answer any questions. I know this is very dense and this may be very difficult, but it just takes reps of remembering and learning why these things occur, right? Cool. So now I'm going to go very quickly over some of the other main vessels that make up the circle of Willis. So we have the anterior communicating artery, and this supplies the majority of the medial surface of the hemisphere. So as you can see, this tiny little guy right here that connects the ACAs, that communicates between the ACAs, is the ACOM. And it's going to supply the area that's going to be more in this region right here, the medial surface of the hemisphere. As you can see here, it's the branches that supplies these structures are going to be the anteromedial central artery. So it's going to be these arteries are going to run up here, posteriorly, and in superior. These arteries are going to be running posteriorly towards the optic chiasm and parts of the lamina terminalis up here at the anterior wall of the third ventricle, as well as superiorly to parts of the hypothalamus and parts of the fornix and cinculae gyrus, right? So as I said before, the ACOM is going to be supplying the structure in this area. So the optic chiasm, the lamina terminalis up here, the preoptic and superoptic areas of the hypothalamus is going to be above this pituitary. So it'll be deep or superior to this pituitary gland right here. The perolfactory areas of the frontal cortex, which is right here, the fornix, which is going to be near the thalamus, which connects parts of the limbic system, and finally the cinculae gyrus, which lays right above the corpus callosum, right? It's very deep superiorly to his brain. So you see it has pretty deep branches going upwards. Moving on, we have the posterior communicating artery, or the PCOM, which will supply the posterior portion of the optic chiasm, optic tract, posterior part of the hypothalamus, mammary arteries, and parts of the thalamus. So this is going to be mediated by these branches right here, right? So PCOM is right here. And it's going to be mediated by these branches called the posterior medial central arteries. And as you can see, these arteries are going to invade the brain medially and will supply the the structures in the brain that are deep, but also medial in the posterior aspect of the brain. So the main one is going to be the thalamus. Below that will be the hypothalamus, right? And the portion of the optic chiasm, right? So the optic chiasm will be somewhere in this area, but the posterior portion of the optic chiasm, as well as the mammillary bodies is going to be in this area right here, right? And parts of the thalamus that you said before. So, so yeah. Also, it's going to be parts of the subthalamus, which is involved in movement and motion. And yeah, so the PCOM is right there. And going back, actually, if I'm going to ask you questions about these arteries in particular, I'm going to circle a part of the brain and say, hey, what part of the brain or what artery supplies this part of the brain? It's going to most probably you can just use your powers of deduction and just say that the artery closest to this area I circle is going to be supplied by that artery, right? So if I circle here, it's really all going to be by the ACOM, right? That point, if I circle here, it's probably going to be because it's in between the PCOM, right? So I want you to say answer PCOM if I circle right here. Cool. So we're almost done, guys, right? A little bit more. So now we're going to go down to the lower down in the posterior circulation, right? We have the pica and the ica. For the most part, this is a good picture to show the pica, right? So right here, right, we have this artery that runs from the vertebral artery, right? So it's a branch of the vertebral. So where do you know it can't be the ica, which is up here, because it runs off the basilar, the ica. So it's going to probably be most likely be the pica, because you see it runs around the medulla, underneath the brainstem, loops upwards and goes back down and curls underneath the cerebellum, along the posterior aspect of the cerebellum, but also the inferior aspect of the cerebellum, right? So if you guys remember from your general anatomy that we had in our first lab, the brainstem is in front of the cerebellum. So the cerebellum is behind the brainstem. So what this means is the anterior portion of the cerebellum is hidden behind the brainstem, right? So right here is going to be the anterior portion of the cerebellum. So this is what the ica would supply, right? The ica would supply this area right here, but behind the brainstem, right? Whereas the pica is going to be supplying the posterior aspect of the brainstem or of the cerebellum, but on the inferior portion of it. So the posterior inferior portion of the cerebellum. And the main symptoms here is going to be general cerebellar dysfunction. So ataxia, vomiting, vertigo, etc. Right? And you see here the SCA, the superior cerebellar artery, is going to come over and supply this portion of the cerebellum, right? The superior portion of the cerebellum. So this will have the same associated deficits such as ataxia, vomiting, and vertigo, right? Cool. So we have two main slides I want to discuss, and the rest of the slide is going to be just to give you exposure to some of these scans, right? But really what I want you to do, what I need you guys to know is how to differentiate a posterior circulation scan from an anterior circulation scan. And as you guys can see here, this is a vertebral angiogram, right? And I put this picture to kind of compare these different vessels in a real, so to give you guys just some perspective, right? Because it just looks like some floating black lines, but this should help give you some context. So you guys can see on this vertebral 3D reconstruction, you can see that they're running up the transverse foramen of your cervical vertebrae. And then at about the C2 to C1 area, it comes out and loops into the skull, and it comes upwards and it becomes the basilar. Up here, you can see that this is around the area of the C2 level, comes up, loops up, C2, loops into the skull, and it forms to become the basilar. And you might be wondering, where is the other vertebral? Well, when you do an angiogram, for the most part, most surgeons only use one catheter, so they can only inject dye one artery at a time. So the other vertebral is still here, but there's no dye getting here because you need two catheters for that, right? One here and one here. And you can see here, though, because of this, it looks kind of like a Y shape, right? Kind of looks like a Y shape. And you see here that this is the vertebral artery, basilar artery, the SCA, superior cerebellar artery. This may be the ica. This may be the ica. I believe so. And then we have the PCA, posterior cerebral artery, and then the PCOM up here, right? So Like I said, now here is where the quiz questions will come in, right? So my quiz questions will be, this is the level my quiz questions will be at. So I'm going to point to this structure right here with an arrow and say, my question will be, what type of symptoms will this patient have if he has an occlusion to this artery? The first step is you need to recognize this is a superior cerebellar artery, right? You need to recognize that this what artery this is, and then you need to think about, okay, what are the symptoms based on the location, right? So because this is a superior cerebellar artery, it's going to be supplying the cerebellum. So if there's dysfunction to the cerebellum, similar to the ICA and PICA, you're going to have stuff such as ataxia, vomiting, vertigo, etc., right? PCA, you're going to have homonymous hemianopia, other visual deficits, maybe even amnesia. Right, so this is the type of question I'll ask you, and I already actually made the quiz. The quiz should already be up actually. So that's literally the questions I'll be asking. I already made them, so it's guaranteed those are your questions, right? So yeah, the reason being is because you're not going to look at a very nice looking model. You're going to be looking at actual scans of patients. So that's why I want to get you guys accustomed to and how to process the information in a hospital setting, because you're not going to have very nice diagrams and models that professional artists drew, right? You're going to be looking at someone's anatomy, which may not look very pretty, right? This is most likely the ICA, but it definitely doesn't look like the model because this is an actual person, right? Nobody's anatomy is perfect, right? Only 30% of people has a full circle of Willis, and 20% of people, their posterior circulation comes from their precom, right? So lots of variation. Now, it's just some more posterior circulation angiograms and stuff. Give you guys exposure. It's already labeled, so I don't really need to go over this. Just in your own time, look over these. Get yourself familiar with the anatomy from different angles, right? Because remember, the surgeon can spin the patient. So I can be showing you pictures from any angle, and you guys would have to be able to figure out, okay, what is going on here, right? And you guys see the labels are all here: PICA, ICA, basilar, superior cerebellar, PCA, right? This is a CTA, a 3D render of the image, right? This is an MRA of the image. And I'm not going to ask you to differentiate a CTA versus an angiogram versus an MRA. That's just very easy, in my opinion, but I'm not going to ask you about that, right? You just have to really know that. And this is a combination actually of the anterior circulation, right, the ICA, and the vertebral arteries. So it's actually a pretty cool picture. Now we have our ICA angiograms. And these look pretty different from the vertebral angiograms, which is very good because you need to differentiate a posterior circulation from the anterior circulation, right? So I have a picture of your internal carotid, right, coming up here, running up here, your neck. And you see there's a lot of twisting and turning as it gets into the skull base. It has to go through your Peters angle, it has to go through your clinoids, the dura, and your cavernous sinus, right? So you see all this tortuosity right here, and the same tortuosity as right here as well. As you can see here, right, when the ICA bifurcates and become the ACA, right, going to the medial portion of the brain, and then the MCA, which runs laterally and will supply the lateral portions of your brain, right? And unfortunately, in these pictures, I couldn't find a very good angiogram that very definitively shows the superior and inferior MCA. But on the quiz, I was able to find some good pictures that clearly differentiate superior and inferior MCA. And I'm going to point an arrow to that and ask you, hey, what are the symptoms, right? Superior is going to be Broca's aphasia and right face arm weakness. Inferior MCA on the left side is going to be Wernicke's aphasia and right face arm weakness, right? And you see this is just a different angle of the ICA angiogram. So this is the lateral view of the anterior circulation angiogram. This is a 3D rendering of a CTA. And this is the same MRA